So continuing on with our osteopathic history project, we are moving to another author again, and what we're doing is using the methodology or the guidelines of the methodology of a textual analysis to look at historical osteopathic texts, especially from the early portion of the profession. We have introduced a constraint package, or a set of lenses through which to examine these texts. Now again, keeping in mind that the texts are purposefully selected by me, so that is a constraint on this process. The other set of constraints is the philosophy of science in epistemology, ontology, and axiology. So we've already discussed those. Hopefully by this point you've heard them repeated enough that we don't absolutely need to repeat them here. What we want to look at briefly before we go into this next author is so far what's happened with our emergent themes, or the themes that are emerging through this examination. Now, these themes already existed, but they're emerging, or we can use the term emerging because of how we're approaching this. Now, what we're noticing is inconsistent epistemology, or inconsistent approaches to construction of knowledge. Some of the authors are more inconsistent within themselves, but the authors, generally speaking, are inconsistent between one another. Now, as far as ontology is concerned, or the classification system, the classification of reality, functional anatomy and the laws of nature are definitely something that is consistent. What is becoming more consistent is the use of diseases, or essentially allopathic disease classifications, to discuss treatment approaches, right? So they're using another category. So they're using functional anatomy to explain how things work. That's a categorization system, or a category within a classification system. The other category is diseases. So we're starting to see the theme of using both functional anatomy as an expression of the laws of nature, as well as more use of diseases as predefined to discuss functional anatomy and to discuss how you would treat something. And the other consistent theme, individual empiricism and prejudice against other pre-existing healthcare practices or healthcare professions, does seem to remain. So the author that we're looking at today, or in this video, depending on when you watch it, it is another day than the day that I'm recording it, so today may not be an appropriate thing to say. Either way, the author that we're looking at or highlighting is Carl P. McConnell. Now, one of the books is McConnell on his own, the other book is McConnell with Teal, right? So it's the second book is McConnell and Teal. Carl McConnell was a graduate of the ASO in 1896, so again, he's early on, so our expectation, should what we've been finding so far remain consistent, is that the themes will stay consistent because he was around quite early on in the profession. The ASO opened in 1892, he graduated in 1896. He was a very early professional within osteopathy. Right, so after graduation, he taught at the ASO in 1897. He also earned an MD from a homeopathic school in 1903, according to the American Osteopathic Association yearbook. He was in practice with his wife, Agnes Russell Darling, in Chicago. And then he was trying to, the claim here, and this is a minor biography attached to the first book that we're looking at, and this is generated primarily by the Museum of Osteopathic History. But through his books, through McConnell's books, he attempted to reconcile Still's philosophies with those of Osler, the father of modern medicine. You can have a discussion about how you view William Osler in respect to being the father of modern medicine. That's not necessarily a discussion that we're going to engage in, but from that minor note, what you're seeing is maybe some motivation to start to utilize the classification of diseases, or the category of pre-existing disease classifications from the allopathic world, and marry that or join that in the ontology with functional anatomy. So explain these pre-existing disease processes or pre-existing disease classifications with functional anatomy. So that you're seeing it in multiple authors at this time, but this possibly gives some motivation or some explanation of motivation for McConnell as an individual. So the texts that we have chosen to examine are both titled The Practice of Osteopathy, the first one being in 1899, the second one being in 1906 with Charles Teal as the co-author, as we already mentioned. So they have the same title and essentially the same aim. They're describing how to practice osteopathy with many pieces of information that McConnell would have thought pertinent to describe the topic. So by simply examining the table of contents, we can see the continuing presence of essentially, so this is the 1899 book, The Practice of Osteopathy. So as early as 1899, with respect to Carl P. McConnell, he was using, you can see how he sectioned the book with respect to pre-existing allopathic terms for disease processes or disease conditions, and then what he's going to do is use that to provide organization for the discussion that he's trying to have. So he begins with his general introduction, osteopathic diagnosis, osteopathic regional treatment, but then he moves into infectious diseases. He uses that as a classification system. Now, that may not have been his purpose in building an ontology. He may not have necessarily had the concept of ontology or in the scientific method or in the scientific process, ontology being the classification system through which you view reality or how you classify reality. But this is evidence that it was something that was done. Whether it was explicit with respect to the concept that we're using in ontology, or whether it was just a way that he felt was most appropriate to organize to discuss what he was trying to get across. We still see this. Now, we saw this in Research and Practice with Dr. Still. While not explicitly noted, this is also how Little John happened to have organized his writings in many cases, not all cases, but in many cases. So we see this consistently over and over again. And if memory serves me properly, we even saw this with Barber, right? So all of these authors are essentially utilizing allopathic diseases or allopathic disease terms to start to center and organize their conversation. So it becomes part of the ontology or one of the categories within the classification system to view reality. So this quote is quite a long quote, the first quote from the 1899 book titled Practice of Osteopathy, but I think there's value in going through it, and this is in the preface. So this work on the practice of osteopathy has been written purely for the practitioner and student of osteopathy. So he's identifying his audience. Up to the present time, there has been little attempt made along osteopathic lines in a literary way. The student has had nothing whatever to guide him in his studies but the notes he has taken from osteopathic lectures, and the practitioner no work to guide him or to refer to in his practice. That it is with many misgivings on account of the science of osteopathy being in crude published form that I publish this work and give it to the osteopathic world. Still, I feel a feeble attempt will be a stimulus to all apostles of the science, and especially so as the art of osteopathic practice is being well advanced. It will never be possible to write osteopathy completely and in detail, as each case is an individual study. The best we can expect is to give the philosophy of the science and to state the principles in general terms. The science is practically unlimited in its breadth and depth are immeasurable. So the first paragraph, identifying the audience, noting that each case, each patient is different enough to identify, or different enough from other cases to be identifiable. So individual empiricism, it's not necessarily explicitly stated here, but individual empiricism is hinted at. Also, this is essentially a guidebook or a textbook. So it's his attempt at a textbook. Again, not explicitly stated, but that would be your general takeaway from that message. So moving to the next paragraph. Osteopathic practice consists first of understanding the normal so that the abnormal conditions may be recognized when met, and second, when these abnormalities are found, of giving specific treatment and readjusting the parts. Practically, to the osteopath, it makes but little difference what the disease is. It is his business to locate the derangement and correct it. This practical work is included in the practice of osteopathy, and it constitutes a major part of this work. Although I have given hydrotherapeutics, nursing, etc., not because I do not think readjustment of the tissues are sufficient to cure many diseases, but occasionally diseases are due to errors in diet, sanitary surroundings, disobedience of hygienic rules, etc. And besides, the proper use of water, food, etc. are important aids sometimes or oftentimes to alleviate suffering, being at the same time not injurious to the patient as drugs often are, especially in diseases that are far advanced. The use of hydrotherapeutics, etc. is of aid. So he's noting a hierarchy. He believes that he's suggesting that regardless of presenting issue, the osteopathic practitioner is looking for the thing that they're looking for. Now I will inject here, it is mechanical dysfunction or abnormal motion as assessed through the means of the osteopathic practitioner. Once that's noted, it doesn't matter what the disease is, you're going to work on what you find. You're not necessarily aiming to work on the thing that relates to the disease, you're looking to work on what's not working. So you're working more on signs rather, less on symptoms, is his general statement here. Also, he's noting in setting up his hierarchy that it is the mechanical discord that's number one, and then the other things, your day-to-day life practices, are number two. So things such as diet and hygiene are of less importance in the patient that is presenting with a particular issue than the mechanical discord. Now, he's also noting a time course, that the further along something is, maybe those things are as useful, maybe early on they're as useful as the actual mechanical. So again, setting up a bit of a hierarchy there. To finish the next paragraph, I've given the old classification of diseases on account of its being universally employed, and an attempt at a scientific classification might cause the loss of many valuable points. As our students are taught according to the old classification, I hope to see an attempt made in the near future to a more scientific nosology. It seems to me that the classification should be based upon the cause of the disturbance, or according to the physiological disturbance the diseases are taken up in a classified manner, according to the best of our practices of medicine as definition, etiology, morbid anatomy, symptoms, etc. This is given in such a manner not because there is anything special to add in morbid anatomy or symptoms, but that it makes the work a complete practice of osteopathy. It is inclusive of the lectures given at the American School of Osteopathy. In a few instances, I have given theoretical treatment of diseases in which osteopathy has not had experience. So that one specifically discusses the use of old classifications to discuss what he's trying to get across. And he's saying that he would have a preference to create a new classification system. So he does have the desire, at least, to attempt, whether it be himself or somebody else, to create a new classification system that would align a little bit better with how osteopathy is trying to get its message across, or the message that osteopathy is trying to deliver. Now, he's noting that this is the standard, that they just happen to use old disease classifications, but if he had his druthers, he would prefer a different classification system. So he is using allopathic diseases to discuss osteopathy. So that is part of the ontology that he's using. He would rather change the ontology if he could. So this next quote from the 1899 version of Principles of Osteopathy is essentially outlining the differences to McConnell between osteopathy and the allopathic profession. So we go into the quote. The refusal to teach materia medica in osteopathic colleges constitutes one of the cardinal points in osteopathic education. I may say here that the two differing points between the science of osteopathy and medical science are quite fundamental. One, the cause of diseases, and two, the cure of diseases. Naturally, the second is quite dependent upon the first. A word more in regard to the reputable colleges of osteopathy. They are not colleges where a smattering of anatomy and physiology is taught with a few Swedish movements and massage-like manipulations. They are colleges that teach minutely each and every branch taught in our best medical colleges except materia medica and drug therapeutics. These colleges of osteopathy court the closest investigation from all classes of people. In fact, it is the desire of the colleges to have their work closely investigated. We have nothing of which we are ashamed and wish honest help in unfolding the details of our teachings. If we are wrong, we are willing to stop. If not, we will win. Our results must speak stronger than words. So, not necessarily noting particular prejudice between allopathic medicine and osteopathic medicine, but noting that there is a difference. So he's not absolutely setting up a hierarchy here. He's noting difference. He's also saying we, at least in his words, that the osteopathic profession welcomes outside investigation, outside curiosity, and possibly outside insight to further expound upon the values of osteopathy. Now, to go to the second paragraph here, or the second portion, we believe and demonstrate daily that the causes of disease are many times due to anatomical derangements. So again, many times. He's presenting less certainty in uncertain circumstances, but still saying that this is the dominant thing, right? So he is presenting a more appropriate level of uncertainty with his claim, but still a higher degree of certainty when compared to other possible etiologies. That the body, being subject to many external influences, disorders of the tissues from an anatomical standpoint occur. Such belief is attacking the very foundation of medical science as taught by the thousands of medical colleges. So this is where there's maybe a minor hint of prejudice. It's not strong, but it's maybe a minor hint of prejudice with respect to the medical profession. So coming to the theme of, as far as axiology is concerned, general prejudice against other pre-existing healthcare practices. Again, this is not a strong sign of prejudice, it's a minor one, while also noting that there is a difference in fundamental belief as to how disease processes present. So another long quote from the 1899 version of the Practice of Osteopathy. Here it's going into essentially more of the ontology and how functional anatomy is the primary way that things are going to be viewed, and this is why osteopathy tends to have more success than allopathic medical systems. So this is, again, a long quote, but we will get into it. Thus, the real cause of disease is displacements of the tissues, not necessarily a bone, as the name osteopathy might imply, but any tissue of the body, chiefly bones, muscles, tendons, and ligaments. That the various atmospherical changes, overwork, strain, slips, falls, blows, etc., are certain to a greater or less extent to affect these tissues and displace them partially or completely, or to strain or to contract them to such an extent that they interfere with the blood, lymph, or nerve force or other fluids, so as to cause unequal or abnormal distribution of these fluids. So to break there for just a moment, lots of words to say, mechanical correlates to health and disease states. Everyone is subject to the effects of atmospherical changes, whether about their work in the day or resting peacefully in their bed at night. A draft of air, a damp day, whether one is warmly clad or not, has a greater or less effect upon the musculature of the body. When muscles are contracted, they at once interfere with the cutaneous circulation and with the superficial nerve terminals, and moreover, when severely contracted, produce traction upon bones, especially the vertebrae and ribs, and tend to draw them from their normal position, and these, when drawn from their normal position, directly interfere with vascular channels and nerve fibers, and thus furnishing the starting point of many diseases. So again, to take a break, further use of a lot of words to say mechanical correlates to health and disease states, particularly in a way that there has not been an attempt to disprove. So they're taking this, this is primarily generated, and this is me injecting some concepts while looking at how this has developed. So this is talking about the ontology, but it also comes from the epistemology, or how knowledge is constructed. The knowledge here is constructed from experience and from what was previously told, and that experience is being built based on an individual empiricism from the outside of a living body. So when he's talking about noting these things, these strains, these relaxation, these contractures from changes in temperature, well, he wasn't there when the temperature changed. He doesn't necessarily know everything about the individual that presents, but he's making these conclusions. So a lot of this is, although sounding fairly positivist, fairly similar to there is one universal truth that can be identified through appropriate experimentation that is true regardless of who looks. He is doing this more from a constructivist point of view. Now, the constructivism has been performed by himself as well as others, but he also, to be fair, was very early on in the profession, so it's unlikely that he would have had the time to get to more of a positivistic position through the work that was done. So this is primarily from individual experience, or a collection of individual experiences. So to go back into it, before I do that, to be sure that the contracture is really having that effect on the nerve. In today's world, you'd have to do a lot more work. You'd have to, first of all, quantify on some level how much that contracture is. So you'd have to find some way to make each individual have that contracture, and then you'd have to see the result in some measurable way on a nerve terminal. So you can set all of those up. You need to create an ontology or multiple categories to measure that. So you need a category for how much contracture, so you need a measurement unit, you need a way to produce it, then you would need a way to measure the nerve or the effect on the nerve, so you'd need a pre and a post, so a pre-contracture, during contracture, post-contracture, at maybe varying time points. You'd need to be able to develop this, and this is not something that they've done. I note this purely to point to the epistemology, how the knowledge was created. And now to turn back to the quote. The strains, falls, slips, etc., to which all are daily subjected have a similar action upon tissues, but more directly upon the framework bones of the body, and cause a strained position of the tissues, thus again interfering with the various fluids of the body. Granted, the repeatedly contracted muscles, strained positions of bones, etc., amount to nothing, no ill effects being derived from them, but how often do they affect us? Just as often as they are deranged to such an extent that nature is unable to cope with the disorder and set them right. Here is where Medicatrix naturae is unable to meet the demand. Then the osteopath steps in and aids nature to set right these disorders. He is unable to do more, nor can he do less. He's simply an assistant to nature as a mechanical engineer of the human body. Now, that term, mechanical engineer, may be a seed, because he's not the only one that would have used this at the time. Dr. Still used this term, but Dr. Still, McConnell, and others at this time point using the term engineer may have been the seed for people to try to invoke the ideas of physics and engineering. They were used as analogies at the time, but that may have been some of the driver for people to start to, in today's world, in osteopathy, consider quantum physics as explanatory to why things in osteopathy work the way that they do. So that's a minor digression. Back to the quote. I quote from Dr. J. Martin Littlejohn from the Journal of Osteopathy, February 1899, as regards the summary of the causes of diseases osteopathically. Pathological conditions may be briefly summarized under three heads. 1. Misplacements of bone, cartilage, ligament, muscle, etc. 2. Disturbances in the fluids of the organism, including the blood and lymph and other secretions of the body. 3. Disorders and derangements of the nervous system, including its centers, ganglia, and plexuses, and fibers. So, again, functional anatomy being the primary categorization system, or the primary category to classify reality. As well, there's the little bit in there about the Medicatrix naturae, and my Latin is not going to be appropriate, but that little piece there saying that the allopaths can't quite get it right, and we do, right? So again, that hierarchy, that minor prejudice as far as a value system is concerned and axiology is concerned between osteopathy and pre-existing healthcare professions. So now moving over to philosophy or practice of osteopathy from 1906, our second book, co-authored with Charles Thiel. We identify another quote here, so we'll go ahead and read it. Osteopathic diagnosis is so physical in its character, depending upon actual conditions found and not upon the subjective symptoms alone, that the same patient examined by a number of experienced osteopaths will give the same diagnosis, and he will also be able to detect in each the same effort to correct it in all their technique. All the methods of physical diagnosis are used, plus the distinctive osteopathic procedure. Results, wherever used, bear out the effectiveness of the system. So this is particularly about diagnosis, but it also points to a belief in positivism. Again, This may not be explicit. He may not have understood positivism as I'm using it to examine his work, or their work rather, because this was two authors or two noted authors. There may have been other people that contributed to the work. But first, what we've noted over time is, at least with palpatory diagnosis, inter-observer reliability is low. So in identifying structures through palpation, there is a low agreement one practitioner to the other as to what they've identified, right? So that is actually a challenge to this that we've been able to bear out over time. As far as the general diagnosis, I don't know that a ton of work has been done on that. To do multiple osteopathic practitioners find the same problem within the same patient. That is less explored as far as I'm aware. However, what is explored is, what do osteopathic practitioners do when presented with a particular case, right? So previously diagnosed mechanical low back pain. And what you'll see with previously diagnosed mechanical low back pain is that osteopathic practitioners, so the same practitioner, one practitioner does not diagnose the same patient the same way. So the practitioners diagnose the same patient differently. They use different methods. That is observed. And the other thing that you'll notice in a new patient, so patient A and patient B with practitioner A will diagnose or go about finding the problem with previously diagnosed mechanical low back pain in patient A and patient B differently. So the same practitioner will diagnose two patients differently. That is something that's been observed in osteopathic practitioners. So osteopathic practitioners do not tend to have a consistent diagnostic approach, even when the condition is previously known. So there is actually some issue that we're able to identify with this going forward through time, where he wouldn't have had, or they wouldn't have had the opportunity to know this information or see it because it wouldn't have developed as well. But when we examine osteopathic practitioners and let them diagnose, they're not consistent between practitioners or even within practitioners. We also know that, again, inter-observer reliability for accurate identification of structures is not good. It does get better when you train them to do the same thing. So it's called consensus training. When you purposely train osteopathic practitioners to diagnose the same thing the same way, or look for something the same way, they tend to agree more. So if there's consistent training and consistent methods within training, you improve inter-observer reliability. They do tend to find the same thing. So they may have been existing at a time where they could look at practitioners who had been trained the same way to do the same thing. But then over time, the training maybe varied. So we have more of a problem with this now. But to note the epistemology underlying this, he's saying that osteopaths essentially are more like positivists, but when we examine them, they're more like constructivists. They do it through individual empiricism. Now, as far as results wherever you bear out the effectiveness of the system, that's a claim to positivism as well. It's a claim that, regardless of who's using the system, the results are good, right? So he's pointing to a consistent truth or a single truth regardless of who looks or who performs it. But I would make the argument that when looking at osteopathy over time as it's practiced, this knowledge that he's talking about is being developed more in a constructivist frame, and osteopathy continues along that constructivist frame. Now we'll talk about that in a subsequent part of this project where we look at today, but I'm just essentially foreshadowing and pointing to that. So this slide and the next slide from the Practice of Osteopathy in 1906 with McConnell and Teal are essentially continuations of one another, so they're more or less united, but due to the amount of text, I've essentially broken them up as slides to discuss them. Now, the quote here, osteopathic etiology distinctively emphasizes structural derangements and perversions. Of first importance is the osseous lesion. So this is setting up a hierarchy within the classification. So this is another part of the classification system. So this is, again, his aim is to talk about the practice of osteopathy, how you actually do it. This is aimed at students and practitioners. So he's setting up a new portion of the classification system, or a new part of the ontology, talking about how to identify lesions or changes in motion characteristic leading or relating to changes in health and disease state. So of first importance is the osseous lesion. The lesion is represented by any abnormal change of position or relation of the many bony constituents of the body. The framework of the body is subject to not only any and every physical violence of any mechanism, but moreover, being the corporeal foundation of vital mechanism, is subject to both direct and indirect biochemic changes and influences. So saying that almost anything that you are subject to, if strong enough, so almost any stimulus you're subject to in day-to-day life, when strong enough, be it biochemical or be it external and forceful, can change the relationships of bones to one another. Thus, the osseous lesion is caused by traumatism, strains, falls, blows, etc. B, indirectly by atmospheric changes, over and violent exercises, etc., through the medium of muscle changes. By C, by nutritional effects disturbing the elements of bony tissue. D, compensatorily and reflexively through the media of body distortions and muscular irritability or debility, e.g. an innominate lesion may be compensatory to a lumbar curvature. Dietetic errors may cause dorsal muscular irritation and contraction and produce a constant osseous lesion, which in turn may result in chronic indigestion. So this is essentially ontologically or classifying reality as your daily life, when the stimulus is strong enough, can change the relationships between bones, and that is the most important thing with respect to health and disease states within the osteopathic worldview. So as far as reality is concerned, your normal life will change the relationship with your bones. Now there's more detail to what he's suggesting here, but he is setting up that hierarchy, that your normal day-to-day life will subject you to things that can change the relationship between your bones, and that can change your health or disease state. So this is the second part of that fairly long quote, setting up that hierarchy as far as classification of lesions, right? From the Practice of Osteopathy in 1906 from McConnell and Teal. So we have the osseous lesion first as far as importance, and then we go into what's presented here. Second in importance is the muscular lesion. Muscular lesion may be an actual dislocation of either muscle or tendon, but rarely. Commonly it is contracted or tensed or contractured muscle. The muscle also may be diseased either from primary, or secondary sources, thus be an etiological feature. The muscular lesion is caused A, by direct or indirect violence, the same as the osseous lesion, B, by atmospheric influence, C, by reflex irritations, B, by compensatory changes, D rather, E, by disease-causing hypertrophy or atrophy, and F, which is the most frequent origin, secondary to osseous lesions, being the result of impingement to the muscle's nervous control. The tensed or stretched muscle results from a separation of the points of origin and insertion. So again, your day-to-day life, when the stimulus is strong enough, is going to do something to your muscles, but usually when we find something wrong with your muscle, it's because the bones got moved or their relationship changed due to a strong enough stimulus in your day-to-day life. Herein, as with the osseous lesion, the fundamental osteopathic concept is the resulting affection due to the physical encroachment, directly or indirectly, of the muscle tissue upon vascular channel or nerve fiber. So the most important thing with muscles is that they're the thing that's more likely to press on blood vessels and nerves, right? Because they can change their tone through neural control. They are more likely to put that pressure on those other structures, because those other structures essentially run in direct contact with muscle. So blood vessels, lymphatic vessels, and nerves run in direct contact with muscle. So when the muscle changes its tone, whether up or down, it can have an effect on nerve and blood vessels, and as well as lymphatic vessels. Muscular contractions, displacements, and tensions play out most important in acute disorders, although muscular lesions that are secondary to other lesions are usually taken into account when treatment is given. Muscular lesions affect A, blood and lymph vessels, B, nerve fibers. Muscular contractions especially impede mechanically the return of the venous blood to the heart. The lesions to the nerve fibers, or to the nerves, may be maintained in innumerable ways depending on the location of the muscle and the function and distribution of the nerve attached. Yeah, the nerve affected, rather. I gotta read that properly. So there are areas where contraction of muscles are a little bit more likely to impinge or put pressure on nerves, right? So the most important thing with contracted muscles is that they affect veins, because veins are low pressure. But then there are these particular points, you could term, if you liked, points of anatomical confluence. You could call them choke points. So things like thoracic outlet syndrome is a term that would be used today commonly. The brachial plexus impinged at a nerve root, so directly upon exiting the vertebral column, impinged between the anterior and middle scalene, impinged not likely but possibly posterior to the clavicle, then possibly impinged in the axilla, so it could be the pec major, the pec minor, a little bit more likely the pec minor. It could be the bicep, because as the brachial plexus runs down with the brachial artery, it's going to follow essentially medial to the bicep, or medial to the bicep, so there may be some impingement there. You have impingement points further on down the arm that don't need to be discussed, but you have these essential choke points depending on the nerve. You know, depending on the path of the nerve, you're more likely to know it's both central and peripheral impingements, is essentially what's being said here. So functional anatomy classifying reality. Then there's the relaxed, overstretched, and atomized muscle. The condition results as a secondary effect of the mechanical strains, these being so severe and constant as to cause direct stretching and possibly tearing of the muscle fibers. This should be distinguished from the exhausted or debilitated muscle, e.g. as found in neurasthenia and anemia. Diagnostically, there are contractions of more or less areas symmetrically due to atmospherical changes. So he's telling you, if you find something that's symmetric, so kind of the whole muscle or both muscles, that's probably an atmospheric change. Here's a challenge: to know that it was atmospheric change, you would have had to have known the atmosphere before. So you would have to know the muscle wasn't contracted or contractured. You would have to know the atmospheric condition, so either barometric pressure, temperature, levels of wind, precipitation. You'd have to know those things, and then so you'd have to know that what its state was, what the atmospheric pressure was. Then you have to prove an atmospheric change, and you have to prove a change in the muscle. This is where I note this, because that would be how you do it as a positivist. However, he's saying, you know, the weather changed, and I know the weather changed, and you know the weather changed, and now you're in this position. But neither one of us can agree that your muscles were not in this state prior to the atmospheric change. I just know that when you show up to me, there was an atmospheric change, and your muscles are in this state. So I have essentially relational data, but it's related in time, right? So that's more of a constructivist, more knowledge depending upon the person observing it, or observing the situation, their previous experiences, and the environment of observation. So I say that because this is a positivist claim, but really it's a constructivist method, so this is an inconsistent epistemology. Anyways, to go back to it, B, the deeply seated contractions involving a very small area caused by vertebral and rib lesions, contractions due to reflex disturbances. D, contractions caused by postural effects and deformities. E, contractions and spasms of blood vessels as a result of nervous irritations. F, contractions due to toxicity of the blood. Pretty much none of these things, as an osteopathic practitioners, are you actually going to be able to figure out with your methodology. The methodology is motion testing. You're not going to be able to figure out toxicity in the blood with motion testing. You can assume it based on other pieces of information that you can put together, so you can essentially do some algebra, right? So you have some unknowns in the equation, and you can try to rebalance it based on previous information, but it's not appropriate observation of your claim. So again, claiming to be a positivist, or a positivist type claim, not claiming to be positivist, but a claim that would more directly map to positivism, but this is constructivist methodology. This depends on the person. We'll move forward. We won't necessarily go through all the details in the next few, but third in the hierarchy, the Ligmantus lesion is usually of secondary importance to the osseous lesion. There are two features that should be noted in particular when considering this lesion: first, thickenings and adhesions, and second, relaxations. It doesn't go much further into it, so how do you identify it? How do you know what it is? It doesn't do that. Fourth, the visceral lesion is frequently overlooked as being of much moment as an osteopathic lesion. I think that may be a typo. Visceral displacements acting as a source of functional and organic annoyance on the physical plane, structural perversion which produces and maintains pressure alone are not in the least uncommon. So they go forth and just talk about, so this, I'll actually read this part. So not directly under that paragraph, but the next one. Visceral lesions are caused A, by vertebral lesions, B, postural defects, C, direct violence, D, nutritional disorders, E, childbirth, F, unhygienic measures, tight lacing, heavy skirts, etc., G, congenital weakness. So again, basically any stimulus in your life in general that's strong enough can cause this, right? So it's a strong enough stimulus can cause this. You can call that, you can essentially call that, there's a particular term, rationalism, right? So the term rationalism, if I can think it up, it must be true. So that ontologically, in a philosophical sense, is more about philosophical idealism, and ideas are the most real things. So because I can do this algebra that nobody's been able to check the proof on, but I did the algebra, so I must be right, right? I can rationalize this, so I must be right. So your day-to-day life can cause enough stimulus to your viscera that it then causes problems, right? So that's essentially a rationalist approach, which lacks an attempt to disprove it. If you attempt to disprove it and it stays, you cannot disprove it, you gain confidence in its likelihood of being correct, but that's not what's done here. Then a long paragraph about particular visceral situations. Then fifth, the composite lesion is not always recognized as an extremely important osteopathic factor, but by composite lesions is meant a structural lesion that primarily includes the osseous, muscular, and ligamentous tissues as a whole. This may be termed a lesion en bloc or en masse. So he's providing you a classification system to discuss the findings of individual empiricism. So when you look at a patient and you use your osteopathic methodologies for assessment, which is motion testing, even at this time, that's what they did. They just tested if things moved, and then they used physical or functional anatomy to interpret the meaning. So if I found a problem between T5 and T9, I could think about a particular region in the splanchnic system, right? So I could think about, if memory serves me, the foregut. I may be missing something there, I may be slightly wrong, this is completely off memory. You know, the foregut, the midgut, and the hindgut, but I believe T5 to 9 is the foregut, right? So the stomach and then the first half of the duodenum. So if I find something wrong in that region, I can then begin to say, oh, this is related to the organs supplied by the greatest splanchnic nerve. I may be wrong, I may not be, but it's the interpretation that becomes how I view reality. So you can call it, you can see that they're trying to do this in a positivist way, saying that this is the truth regardless of who looks, but really it's a constructivist methodology. They're trying to build this knowledge by saying, I looked, these are the areas that I found, I did the algebra, and this is, so there were some unknowns, and this is what I came up with, so I'm definitely right. That is not as accurate as it would like to claim it is, and this is why you end up having some problems with the claims made by the profession because of the way the knowledge is built. And you're seeing this over and over again. They're making these claims that this is the singular reality regardless of who looks, but they're doing it in a method that totally depends on who's looking. So long quote the categorization system for discussion, but realistically it's not what it claims to be, claiming to be a positivist thing, but really it's a constructivist thing. So now that we've gone through the quotes from McConnell and Thiel, or McConnell and Thiel, but primarily focusing on McConnell because he's the uniter of both of those works, with both books being The Practice of Osteopathy, one from 1899, one from 1906. We map that against the themes that we've already identified. Now, again, just to note that when we say emergent, we're saying emergent from this process, not emergent necessarily from those works. When you tie these works together, you're noticing the themes that are similar, so you can call it emergent, but realistically those themes already existed, but it's the process that we're going through that, you know, makes these emergent. Still inconsistent epistemology. There's inconsistent epistemology with respect to McConnell's work in both books, in that he makes positivistic claims, but really they're constructivist methods, so that's inconsistent. Now, he may not have seen it that way. He may not have understood those terms in the way that I'm using them, so we have to be fair, but that is what we can identify when we look back, right? And when we look back through those lenses. Functional anatomy and diseases as ontologies does seem firm, so functional anatomy as the explanatory mechanism, that's what's most real, as the interpretive mechanism, and then using the diseases, allopathic disease classifications, as how you classify reality does seem consistent between all these authors. It's the method that they use. Now, according to McConnell, it's not the method that he would prefer, but it is the method that's used. So he would, if he had his way, develop a new classification system, but this is the one that they are using. So there is at least some admission in an explicit way that that is just how it's done. Then individual empiricism and prejudice against other systems does remain. McConnell is not particularly aggressive in his prejudice against the medical profession. However, he does set up a hierarchy that does suggest that osteopathy is the best.